We then come to the secondary survey, and the first thing we do is to take a history, which is concise, usually guided by the mnemonic AMPLE. AMPLE stands for information we got from the patient, any history of drug allergies, any medication the patient might be under. For example, some patients who are on beta blockers will have a slow heart rate in spite of their blood loss. We want to know the patient's past medical history, the patient's last meal. This is important if we're considering surgery. Last, actually, but most important is the events. In the events, we want to know what happened, which helps us to determine the mechanism of injury. We also want to know the duration from the time of injury of the patient, and we want to know details about environmental impacts, etc. We then do a head-to-toe examination of the patient, starting of course from the head, in this order so that we do not miss anything, and in this case we do a more thorough examination. In the head, our interest is any areas of injury in the skull, the ears or nose. We check for CSF fluid leakage, signs of mesoskull fracture, check for any maxillofacial injuries, and any obvious or even hidden. In the eyes, we check visual acuity, we check for raccoon eyes, which is bleeding around the eye, for anisocoria, that is unequal pupils, for hyphema, which is blood in the anterior chamber or posterior chamber, and in this we do fundoscopy, and if a patient has any contact lenses, we must remove them. In the ears, we check for blood in the middle ear, hemotympanum, and any bleeding through the ear or any cerebrospinal fluid leakage, and we remove any hearing aids. In the nasopharynx, we check for any blockage and any bleeding, and we also check for any dental injuries and remove any dentures the patient might have. The problems with the oral or nasal cavity are especially serious because they compromise the airway. Then check the neck for any bleeding, swelling, anything that might cause injuries to either the neurovascular structures there, the carotid arteries, vein, the jugular veins, and we also check for any tracheal injuries. In the treatment, we maintain an airway, well-ventilated patient, put patient on supplemental oxygen. Actually, the patient should already be on supplemental oxygen, and we manage shock aggressively. Controlled hyperventilation means the patient requires ventilation but not very rapid bagging, which might cause them to have hypocarbia that will lead to cerebral vasoconstriction. We do a rapid CT scan if we identify any injuries in the head and neck region, and we also evaluate spinal cord injuries appropriately. Chest injuries are also very serious and very important to manage early because they compromise respiratory mechanics, and we need to evaluate those very rapidly by inspecting for any signs of trauma, chest movement, whether there's any paradoxical movement, palpate for any crepitus or tenderness, listen for breath sounds, and we need to treat the patients early if we discover these injuries. In abdominal examination, any obvious signs of injury, sometimes since we may not see any, we need to determine quickly for patients if if a patient has any internal injury through using FAST, that is focused abdominal sonogram for trauma, then ultrasound in examination. We also use diagnostic peritoneal lavage and CT scan. And if a patient has abdominal injury, they might require a laparotomy, and prior to this we need to manage patients in shock. Part of abdominal examination is genitourinary examination. We inspect the perineum, the anus, vagina for any injuries. Do a rectal examination to assess the prostate, its tone and position. We put a Foley's catheter, but first we must make sure the patient does not have a urethral injury, and this we do by inspecting the urethral meatus and also feeling for the prostate to make sure the prostate is not high riding. And we put an nasogastric tube to decompress the stomach, and we might also need the same to give contrast for an abdominal CT scan. And the extremities, usually extremity injuries are so overt and they tend to rivet our attention, but extremities should be examined after the other more important examinations we have talked about, and we inspect for any deformities, any bleeding or lacerations, and we palpate for peripheral pulses, for crepus, which indicates fractures, and also for any tenderness and sensation, and we obtain the appropriate x-rays. The initial management for the extremities is to apply splints to immobilize any fractures and to reduce any dislocations that might occur, and pneumatic and shock garments also do help in the immobilization of these injuries. We must also give tetanus immunization, and very important to determine if a patient might have compartment syndrome. In the spinal cord, we need to know spinal cord levels, that is, we need to know dermatomes, so that if a patient has got any injuries, we can be able to tell the level of the injury. Some of the investigations that are required are very important: a full hemogram, sugar, grouping and cross match. For abdominal injuries, we'd also like to do urinalysis, serum amylase. Then we also need to determine the function of the kidneys by doing creatinine and urea. At this point, we also order other x-rays that are required. Then, in the definitive management, after the secondary survey, we call the appropriate consultants and refer the patients to the necessary specialized areas for treatment. For example, intensive care unit, theater, or acute trauma ward. Definitive care, of course, will also entail the full recovery and rehabilitation, which is usually the work of specialists in various areas. In summary, therefore, the goals of initial assessment and management are to rapidly assess and stabilize an acutely injured patient by managing the conditions that might cause severe injury, for example, the airway and ventilation, hemorrhage control, and spinal mobilization. We need expeditious treatment of injuries and transfer to areas of definitive care. Thank you.